All right, so I think we can start now as the participants keep joining. So this morning, I would like to welcome everyone to the first local media training for journalists and health communicators responsible on reporting responsible for COVID-19. I am your host, Angela Hoyt, and I am the Knowledge Management and Communications Focal Point at PAHO, the Guyana Country Office. Now, today we have very interesting training we have for the journalists, and we encourage all the journalists who are on to encourage their other colleagues to join. A lot of information will be shared today. So first, we will have two briefings from our own Dr. Luis Codina, which is the PAHO WHO representative, who is new to our office, and Dr. Frank Anthony. So we will start with the formal part of it, and when we go into the panelists, I will introduce each panelist to the team. So Dr. Codina, you have the floor.
Thank you, Mrs. Angela, and Honorable Minister Anthony, colleagues from Guyana and CMU and others in Washington, and consultants, media specialists. Good morning. I would just like to say a few words to support our colleagues at the ministry. I think this is an important training for you, and we hope that you will support the entire webinar to be edified on the skills. No? This is organized to reinforce your skills, no? To define better what type of information to share, it's important to share, and how it should be shared, no? And what mechanisms, which are the mechanisms to better share all this information. We are currently, as you know, suffering infodemic, and we need you to understand the dynamics in share the right information, no? So that the people do the right thing and not to be confused. I must say that this type of training is normally done face-to-face, but unfortunately, we cannot do the COVID-19. Also, it's very important, I think, to say that we don't have yet all the answers in terms of COVID-19. And I think that sometimes this is very pushing a lot the journalists to have the last information, the better information. But in this case, it's not possible. So I think the journalist has to deal with two words. One is patient, and the second one is evidence, because this is very important to show, to see the evidence, to search all the evidence that exists, and then publish or disseminate. But also to have patience, because this is, I think, one of the cases that we don't still have after the beginning of the pandemic, all the responses. And we, as in our lifestyle, we want the responses rapidly. Sometimes it's not possible. So I think the patience and the evidence, we have to balance all these two words in a good way. So PAHO is very committed to continue the collaboration with the Ministry of Health and the media. So that is, this sector may remain a key partner, and it's a key partner in all these efforts led by the Minister and the Ministry of Health to build a strong health system for a healthy Guyana, and also to better respond to COVID-19. Thank you so much.
Thank you, Dr. Codina, for those welcoming words. And now we will ask our minister to share some brief remarks. Also, so Dr. Anthony,
thank you very much, Angela. Dr. Codina, PAHO WHO representative here in Guyana. Dr. Carpen, who is our lead cardiologist at the Georgetown Public Hospital. Members of the media, the colleagues from PAHO WHO who are in Washington and would be facilitators of this workshop, friends all. Indeed, the ministry is quite happy to collaborate with PAHO WHO as we run this virtual workshop for the media. We believe that the media has a very important role to play in this pandemic. And as Dr. Cordina emphasized, one of the things that we notice with the pandemic is that you also have what is called an infodemic, and where we have a deluge of information that is spreading just as the virus has been spreading. It is going fast. It is going, further afield. And a lot of times it's a lot of false information. And this really has been amplified by social media. And sometimes it's quite challenging for us to combat the myths that have been created and that have been circulated on social media, which really brings us to the role of the media. And that is, we want during this pandemic for you to help us to get accurate information out to the general public. We know that here in Guyana, we have been doing a fairly good job of getting that information out. But one is about reporting, and I think you've been doing that, in a very big way. But also another role would be in helping us to educate the public. And I think in that area, we can do a little bit more. Because as was said, this is quite a new disease. We just learned about the disease last year, December, and we are still discovering so many things about the disease. So for example, at the beginning, we didn't know, the genetic composition of the virus. We didn't have accurate tests. Now we have all of those things. But as we discover more about the disease, how it spread, other manifestations. So initially we thought it was just happening with your respiratory tract. Now we know that there's other forms of it which can affect other organs of the body and so forth. And now there's a lot of conversation around things like long COVID. Now, if we are going to help our public to better understand this disease, then we will really count on the media to assist us in helping to educate the public. I think you are a go-between between the medical professionals who have been studying and have the knowledge of the disease and the public who needs to know more so that they can take preventative actions. While we work on educating the public, it is also important that we get the public to comply with measures that can keep them safe. And in our society, while most people are working on that compliance and by and large have been taking the precautions, we still have pockets of people who believe that they're invincible to this disease. And therefore, how do we reach them? How do we get them to change their behavior? And we believe that a lot of this information and getting people to change can be modeled if we have our media helping us to do so. So I think this would be, in this workshop, we want to explore many of these topics. And we want to build a relationship with the media because we recognize that the voice that you have in the population, the influence that you have, can help us to achieve our public health goals, which is really to keep the citizens of Guyana safe, not just in this pandemic, but also to get them to understand about some of the other health challenges that we have. So this perhaps would be the first step in building a long-lasting relationship with the media. And we are here to work with you to ensure that you can better understand more about this disease. Because I think if you're going to be able to do accurate reporting, one of the things that you have to know is to know more about the disease itself. And so that once you have that knowledge, you'll be better be able to explain it to the general public. So we look forward to having a very good virtual workshop. I want you to ask as much questions of the panelists as possible so that you leave here with more knowledge about this disease so that it can help you to do your job of reporting and educating the Guyanese public in a much better way. So I thank you very much, and I wish you well in this workshop.
Thank you, Dr. Minister, Dr. Frank Anthony, for those words. And I am sure that the attendees will, take the knowledge that they would have received today and apply it to their work. So moving on, we will go to our panelists. Now to introduce each of our panelists, our first presentation will be done by Dr. Eldona Boson, and Dr. Boson is an epidemiologist serving in the Caribbean. She works with the ministries of health and other partners to provide technical support to the national and regional programs in the area of epidemiology, surveillance, statistics, outbreak investigations, and the production and dissemination of health information. Just to give a short background of the work Dr. Boson does. So Dr. Boson, if you can start your presentation, you have the floor.
Thank you very much, Angela, and good morning to everybody, Dr. Codina, Dr. Anthony, our participants, the journalists, as well as my colleagues and fellow panelists on this training. So thank you so much for inviting me to share a little bit about epidemiology, the basics of epidemiology, and I will also try to apply some of it to the COVID situation, but I'm not going to be giving you facts and figures about COVID because no sooner the words come out of my mouth than they are dated. So I would more try to guide you as to where you can get ongoing up-to-date information as the presentation goes on. So let me just share my screen here. Angela, do you see the screen well?
Yes.
Yes.
Okay. Perfect. So as I said, I'm going to speak a little bit about some of the key kind of epidemiological concepts that you need to understand in the context of COVID-19, so that when you see things, when you read things, you have a clear understanding and you are able to repackage it in a way that the public can understand. Okay. Why is it not moving? Just bear with me. For some reason, it's not moving. I don't know why. Oh, okay. Okay, great. So I want to start with a basic definition of epidemiology. It's a word you've been hearing a lot about since this whole pandemic began. So epidemiology can be defined as the study of the distribution, determinants, and control of health-related conditions or events in a population. So that's quite a mouthful. I want to break it down a little bit. When we speak about a study, we could be talking about surveillance, which you're seeing a lot of. We have a lot of surveillance going on with COVID-19. Daily, you keep hearing about the numbers and cases and so forth. We could also, however, be talking about research or observation. That is another type of study. But for COVID-19, for the most part, we're looking at surveillance data. And what are we studying? We're studying the distribution. Who are cases? Where are these cases occurring? When are they occurring? And we're looking at determinants. What are the factors that influence health? You keep hearing about things like comorbidities. And what are the causes of the disease? The SARS-CoV-2 virus, for example. We also study in epidemiology how to control the situation, how to handle a problem We've been hearing a lot about that with COVID in terms of the public health measures you need to take, your PPE, your hand washing and mask and so forth. So we're studying distribution, determinants, control of health-related conditions or events. Now, these are usually diseases like COVID-19, also things like causes of death, but we also look at health-related behaviors, how you eat, your diet, exercise, other behaviors, sexual behaviors, smoking, those types of things. And we look at populations, normally people, but sometimes you might investigate a population of things like vials in a batch of vaccines, for example. So epidemiology really does a wide scope of things and is really key to what we're doing now in our response to COVID-19. So let's just back up a little bit. We know in December 2019, this is when it all began, when there was an acute respiratory syndrome of unknown etiology that occurred in Wuhan, China. So they knew something was going on, but they didn't know what it was yet. Eventually, with some testing, they were able to determine it was something new. It was not one of the usual viruses or bacteria that they see, and it was actually a novel coronavirus. Because it was discovered in 2019, it has 2019 in the name. On the 11th of February 2020, the disease was named COVID-19. And as you see, that comes from coronavirus disease, COVID, 2019, the year it was discovered, so COVID-19. It's a new normal way of naming viruses. So the virus, however, that causes the disease is called SARS-CoV-2. For severe acute respiratory syndrome, coronavirus 2. Why 2? Because we had one before. If you remember some years back in China, as well as in Canada, focused in Toronto, we had SARS, and that was caused by SARS-CoV-1. So this is SARS-CoV-2. And the COVID virus is actually from a family of coronaviruses that cause from very mild disease to the common cold up to severe diseases like COVID-19, SARS, MERS. So there's a wide group of coronaviruses in the coronavirus family, and COVID-19 is the latest to that group. Another term you may have heard, I'm sure, at the end of January on the 30th, is Public Health Emergency of International Concern. The acronym is FAKE, which is unfortunate because it is most certainly not a fake. We all wish that it was, but it's not. Only one person can declare fake. That is the WHO Director General, who at this time is Dr. Tedros Ghebreyesus. And a fake is defined in the international health regulations as an extraordinary event, which is determined as provided in these regulations, so I'm quoting here, to do two things. One, constitute a public health risk to other states through international spread of disease. And as I'm saying this, I'm sure you're registering a tick for COVID-19 there. It also potentially requires a coordinated international response. Again, another tick for COVID-19. Once something, an event, is defined as a fake, it implies that the situation is serious, unusual, or unexpected. It has implications for public health beyond the country where it started, and it might require immediate international action. Again, ticks all around for COVID-19. So once we have an event, it will be the Director General of WHO who will, based on a committee of experts who would be put together from throughout the world, experts in relevant fields, they will advise the Director General whether the event constitutes a public health emergency of international concern or not. Based on that advice, the WHO Director General will declare or not a fake. Along with the declaration of a fake, you must have temporary recommendations, which would include health measures that have to be implemented by states parties or countries that are experiencing the event, and by other state parties who may be under threat of the event. And these recommendations aim to prevent or reduce that spread of disease and also to avoid unnecessary interference with international traffic and trade. So let's move on a little bit again. So after we had SARS COVID-19 declared a fake, on the 11th of March, it was declared a pandemic. So what does that mean? I would like to define a couple other terms before that. Endemic. Endemic is the usually occurring levels of a disease. So we say, for example, things like dengue or gastroenteritis are endemic. We always see some of it occurring. Sometimes the numbers increase, but we always have it occurring at low levels. These are what we normally expect to see. An epidemic is when you have an increase in cases clearly in excess of what is expected, clearly in excess of that endemic level. So if you normally expect to see sort of between 0 and 5 or 6 cases, as you see on this little graph here, that is your endemic level. And then if it goes above that, so it's more than you expect to see, you have your epidemic level. Now, of course, you cannot know if you have gone above what is expected if you do not know what is expected. So it is important to have surveillance going on so that you know when you have gone above that endemic level and gone into an epidemic phase. You also hear the word outbreak. An outbreak is just another word for epidemic. It means exactly the same thing, more than you expect to see. Somehow, though, the word outbreak tends to instill a higher level of fear and pandemic and concern. But it means the same thing. It means epidemic, more than you expect to see. And pandemic simply means that you have an epidemic or outbreak worldwide. It occurs in all regions of the world. And so we are now, since the 11th of March, in a pandemic of COVID-19 because it is now everywhere in the world. The last pandemic we had before this was H1N1, an influenza pandemic. It was a milder disease, but that was the last one that we had that was worldwide and therefore a pandemic. So to use the terms, for example, global pandemic is a little bit redundant because the word pandemic means that it is global. Just a quick note about cluster, you may hear that as well. That's a group of cases that are clustered either in time or in a specific geographic area, or they have the same exposure. So a cluster may be an epidemic if it's above what you expect to see, or it may be within endemic levels, but it is clustered somewhere or in some period of time. The other thing you may hear about is epicurve or epidemic curve. This is a typical point source epidemic. This kind of curve, it describes when an outbreak starts. It normally has on the y-axis the number of cases that are occurring. And on the x-axis, it has time. So on this x-axis here, we have you have the date of onset of disease. And let's say these are just days in a month, the 8th, the 9th, and so on. So this tells you that the outbreak or epidemic started on day 9. It tells you that it ended on day 21. So you know the duration was from the 9th to the 21st. It gives you an idea of the magnitude because you can see along here how many cases. To get the total, you add those up. It also gives you an idea of atypical cases, cases that may have occurred sort of after you may have had a break. Sometimes you see a longer break and then a case occurs. So it's a way of describing how the outbreak is taking place. You get a sense of when the outbreak has peaked, when it is still increasing, when it has started to decrease or peter out. So this is a point source outbreak. That point source, though, is not what we're seeing with COVID-19 because we have a continuous source taking place. Therefore, what we have is called a propagated epicurve. It keeps occurring again and again normally separated each peak by an incubation period, which I'll speak about a little bit later, what that is. But it sort of goes on, peaks and troughs continuing along the way over a period of time. So this is a propagated epidemic curve. I also want to speak about frequency graphs, simple versus cumulative. On the left, we have a simple frequency graph. What this shows, again, cases on the Y, dates along the X. Same thing with the cumulative. But what this shows is the number of cases occurring in a specific time period. On this graph, that is daily. Sometimes it may be by week that they show, and even by month in some instances. But this one is daily. And therefore, you're clearly seeing that in the beginning, you had very few cases on a daily basis. But as time is going on, you're getting more and more each day. Cumulative is where you add each day. So on day 2, you have the cumulative numbers for day 1 and 2. On day 3, 1, 2, and 3. So with a cumulative graph, you would always see it going up until eventually when your outbreak ends, it will then just plateau there because you are adding each time the subsequent day. So a cumulative graph always has this kind of shape. A frequency graph may have this shape, but it may not. So you need to be very careful when you look at graphs to see what kind of graph it is. Look at the title. It's important as well to look at the units. That also helps to give you an indication of frequency, whether it is a simple frequency graph or cumulative. So I put here, for example, a graph that you may see. This was taken from the PAHO website. New cases, so this is a simple frequency graph on the left, and on the right, the cumulative. Again, I want you to look at the y-axis, the numbers there. So this is the cumulative cases of COVID-19 cases in CARICOM countries and associated countries and French and Dutch territories. The different colors represent different countries. I didn't put the country names there because it would make it too congested. But if you look here on the left, you can see that we have on a daily basis cases that are occurring. So we had a peak here and then it went down. And then around July, we had another peak and then it went down. And there we're in a peak again. And if you look, we're seeing that this is 1,500, 2,000, as compared to here, 50,000, 100,000. And you see this is continuously going up because every day we're adding the day before. I wanted to show you this graph that shows the COVID-19 cases reported weekly by WHO region in different colors, and the line showing the global deaths as of the 15th of November. So on this side, we have the cases. On this side is the deaths as it relates to the line. Now, if you kind of ignore the colors and just look at the bars overall, what we see is that from when the outbreak started on the 30th of December, it seems to be going up all the time. So at a first look, you might think, oh, okay, maybe this is a cumulative frequency graph. But the title tells you that it's the cases reported weekly. So this is telling you each week how many have been reported. So now we can see back in December, January, February, when cases were occurring in China, and we thought, oh my gosh, this is a lot going on. Compared to what's happening now, it's really not that much. What we can also see from here with the different colors is which regions were affected the most when. So in around March, you can see up to sort of beginning, March, you can see in green, Europe was the epicenter. And that was when we heard about things happening in Italy and Spain and so forth. But then towards the end of March, the Americas in yellow started to take over. And we can see by April, the epicenter was the Americas. And this continued right through until now again, we're seeing that Europe has now taken over as the epicenter. So there's a lot of information in this graph. And it's really important to look at the titles. And again, if you look at the numbers here, 4.5 million, you know that we're well past that. We're over 53 million globally. So we know this cannot be cumulative. And then the line shows us the deaths, and we can see that we had some peaks and troughs and peaks again. So globally, we actually have not yet peaked globally. We are still almost in our first wave globally. And in fact, if I were to show the graph for the US is also still in its first wave. They had those little peaks and troughs that I showed you in the propagated graph, but overall still going up. So let's look a little bit more about the curve. You've heard a lot about flattening the curve. Sometimes they say delaying the curve, and we're talking about an epicurve, cases over length of time. Now, if it is we have no preventative measures in place or not enough, what you will find is that you would have a very steep incline. At some point when you get herd immunity, when most people have been infected, you will find that you will then have a decline. But if that were to happen without putting preventative measures in place, there will be a lot of death, a lot of illness while we get to herd immunity. Our concern has always been, if this is the healthcare system capacity, how much the healthcare system can take care of. If the number of cases go above that, we have the horrible situation where we do not have enough healthcare to deal with all the sick people we have. And remember, COVID is not the only disease around. There are still others taking place. So what all countries have been doing, putting measures in place to try and make sure that we keep the number of COVID cases below this level that our healthcare system can take care of, so that we don't have that unfortunate position where we have to make decisions as to who gets healthcare and who does not because we don't have enough. Reproduction numbers or rates, RO and RT is another term you would hear about. What this really looks at is the potential for disease to spread. It's really the basic reproduction number. Sometimes you hear it called reproduction rate, same thing. The RO is the basic one. And what it is just the average number of new cases that is caused by one case in a population where everyone is susceptible. Nobody has had it yet. Nobody is protected. Everyone's susceptible. So if, for example, every infected person passes it on to 2 people, then your RO is 0. The difference between RO and RT, RT is the effective reproduction number. This is when you have some immunity or intervention measures in place. So in all our countries now, we would be looking at RT because we all have interventions in place, whether it's using masks, hand washing, physical distancing, restriction of movement. So this is the effective, in other words, the real one, given the reality of the context. And the effective reproduction number changes as some of the population becomes immune, whether by being infected or whether by vaccination. And also it changes according to the interventions you put in place. So just to give you an idea, if your RO or RT for that matter is greater than 1, in other words, for every ill person, more than 1 is infected, then what you have is your outbreak is increasing. And the bigger your RO or bigger your RT, the steeper the increase is. And that means the more at risk anybody in the population is of getting the disease. Sometimes you hear your healthcare professionals saying that we have plateaued, we've reached a plateau. That is when your RO is 1 or RT is 1. For every ill person, they infect one other. So you're not going up, you're not going down, you're just plateauing. And what we're aiming for is for RO to be less than 0. For every person infected, they're infecting less than 1 on average. I mean, obviously you don't infect a portion of a person, but when you add up all the ill people and all those infected, it's less than 1. And this is what we're really aiming for, to get your RO or RT down to as close to 0 as possible. So speaking about immunity, Immunity is when you're not susceptible to disease. It is when you're able to produce antibody to the disease, and so you do not get ill. This can happen if you've had prior exposure to the disease, and so your body it has the recipe to be able to react and build the antibodies that can kill the disease that has entered your body. Because when a disease comes into your body and your body has not seen it before, it doesn't know what to do. It cannot make the antibodies fast enough. It doesn't know the recipe. But if it's seen it before, either by being infected or having had a vaccine, it already has a recipe. So it just puts everything together and descends on the virus or bacteria, whatever pathogen it is, and kills it before it can multiply and make you ill. So somebody can become immune either if they've been ill before or they've been vaccinated. Part of the problem with COVID-19 is we don't know how long immunity lasts. We don't know when you become immune, how long does that memory remain in your body that keeps you immune before it forgets the recipe and you're now susceptible again. Related to immunity is herd immunity. This is protection from a disease, and you have herd immunity of a population, not of a person. It's protection from a disease when a large enough proportion of the population has become immune. And that large proportion that is immune gives indirect protection to others not immune. So for example, if 80% of your population is immune to a disease, either because you're vaccinated or they've been ill, it means then 4 out of 5 people, 80%, who are in contact with a case will not get sick. It means 4 out of 5 people, if even they came in contact with a case, will themselves not spread the disease. And so in that way, the spread of the disease is kept under control because you have a large portion of your population, large enough portion that you don't get enough people getting sick to spread to others. Because if you have less sick people, it gives that level of immunity to what we call the herd, and hence the word herd immunity. So that will be what we're aiming for with vaccination, because we can vaccinate people without them getting sick. But if we aim for herd immunity by just allowing the disease to spread, at some point we will get there, but we will kill a lot of people on the way. Couple other terms, incidence and prevalence. Prevalence is the measure of the total number of cases in a population during a specified period of time. It tells you what's your burden now. And if you look at this little jar here, so prevalence, if you look at the ball part of the jar as your population, this is the number of people you have now. It's affected by 2 things, the incidence. Incidence is the number of new cases during a specified period of time. So if we're speaking about today, we might say that in a population today, they have 2,000 cases, but today, and that's the prevalence, of those 2,000, maybe 200 became cases today. That's your incidence, the number of new cases. What also affects the prevalence is how many people get well, how many recovered, because once you've recovered, you're no longer in that pool of prevalent cases. Or, unfortunately, if you perish, you're also no longer there. So your prevalence gives you an idea of how much you have to deal with now. Your incidence gives you an idea of your risk of contracting the disease. Because if you have more people becoming ill at a given point in time, let's say per day, it means that you are at greater risk. You have more of the disease circulating. So coming close to the end now, the natural history of infection. And I'll just go through this. When you are not infected, it means you are susceptible. So once you've not had the disease, let's say take COVID, for example, you are here. You're susceptible because you haven't had it. Whoops. You may become exposed. And when you're exposed, you go through a period when your body is not showing any symptoms, but some changes are taking place because the virus is multiplying inside of you and beginning to make some changes. And then at some point, you may show symptoms. Now with COVID-19, we have seen that some people never show symptoms, but some will. And this is actually a chart for any infectious disease. And I'll relate it to COVID in a minute. So most diseases, you get symptoms. Now this period between when you're exposed, so you've come into some contact with someone with the disease, but you're not showing symptoms, is your subclinical period until you show symptoms. And this, I made reference to the word incubation period. From exposure to when you have symptoms is your incubation period. So somebody can be walking around looking perfectly well and they are incubating the disease. Once you have symptoms, it is normally a little after that that you will have diagnosis, because normally you will not seek health care or be tested for a disease unless you're ill. You have your symptomatic period when you're showing clinical symptoms. You call it your symptomatic period. You're showing symptoms. And then at some point you will get over or you will perish. And you call this your stage of recovery or disability if you end up with a long-term complication or death. So you go from being susceptible to incubating, no signs and symptoms, but something's happening in there, to showing signs and symptoms, to no longer showing because you've recovered or perished. Now, COVID-19 infectious period, unfortunately, starts a little before the onset of symptoms. By and large, this outbreak is fueled by persons who have symptoms. There has been some evidence of transmission from persons without symptoms, but by and large, it is driven by persons with symptoms. So you can become infectious from a little before your symptoms and continue during mostly the first few days after you become symptomatic, but up to 14 days thereafter, you can infect other people. And this is why we speak about having quarantine for 14 days after the onset of symptoms. Oh, one more thing I wanted to just say here. Because you have this period when you are building up virus and you then get your onset of symptoms, but you're infectious a little bit before, it means that one can be infectious with COVID-19 during that incubation period when you are not showing symptoms. During this incubation period as well, you find that your laboratory tests can give you false negatives. You generally will get a positive test round about the first couple of days before you start to show symptoms, will be the earliest you would get. But initially, when you are just exposed, you will not have yet enough virus built up to show up in a test. So if you were exposed here, you infected here, the exposure period, and you did a test the day you were exposed, or up to about 2 or 3 days after you were exposed, while you are incubating, but the virus is not built up enough yet, your test would be negative. And then after about 2 or 3 days after you've been infected, then your test will be positive. So having a negative test, even a PCR test, this is a test I'm speaking about, can give you a false sense of security of being negative. It tells you you are negative at this point in time, but you could possibly be incubating the disease. When you will get a positive test will be from about 2 or 3 days before you start to show symptoms, up to could be as long as 14 days after, but usually within about a week after. So what I would encourage you to do, I did not really show facts and figures here because they change very quickly. I would encourage you to stay informed from reliable sources. The World Health Organization website has global data updated every day. The PAHO website has data that is updated every day for the region of the Americas. Within the PAHO website, we have 2 data hubs, one for the CARICOM subregion and one for the Caribbean, which will include the territories as well. And they have their own data hubs there as well, and they change on a daily basis. The Ministry of Health website, if you want to look at specifically Guyana, they will have their information and they will be a reliable source for national data. Be very, very careful of data that is circulating on social media. There's a lot of very believable things that you see on social media. Be very careful. I encourage you to try and verify with your ministry, with your PAHO office, things that you see that maybe you've not heard before, don't resonate well, sound a little bit strange. Do verify, because there is, as Dr. Kadina and Dr. Anthony said at the beginning, a lot of misinformation circulating. So be sure that when you put out information, it is reliable information and you are assisting your ministry with educating the public, because we're all in this together. The ministry cannot handle this outbreak alone. They need the population's compliance, and you can certainly help in that regard. So I thank you for your time and hand back over to Angela at this time.
Thank you, Dr. Boson. That was a very comprehensive presentation. Now, if anyone has any questions, you can place them in the chat or you can raise your hand. So, but due to time, we can move on to the next presentation. Dr. Carpen, he has a competing meeting too. So Dr. Carpen? Dr. Carpen is a certified cardiologist and cardiac electrophysiologist. He is currently the head of the medical services and the cardiology at the Georgetown Public Hospital. So, Dr. Carpen, you have the floor.
Thank you very much for inviting me to be a part of this panel. Once you can hear me, I think I'll just go straight into what I have today. So to look at the clinical aspects of COVID-19, one needs to understand that this is a process that starts quite a while before actually would have developed symptoms. And just to emphasize some of the points that the previous speaker would have made, by the time patients get to hospital or get to clinical attention, that's not the first time that they would have become sick or they would have been exposed. They were exposed for quite some time before. So I'm quite sure that all of our media attendees and everyone on the panel are quite familiar and are somewhat experts at social media and all the various means of communication. And if you were to scroll through anybody's timeline or generally, there's at least one or two persons who are going to post some things that will stop you a little bit in your tracks. And some of the claims would be, the common one is, my family caught COVID in the hospital and we don't believe that they were positive, etc. And part of my goal today is to try and highlight what can be true and what may not be true about those kinds of claims. So we look at COVID as a clinical entity in 4 stages, really. The main one that we start with is what happens before symptoms actually start. Then there's a symptomatic phase, and then there's either recovery or hospitalization. And what we have been paying a lot of attention to recently is the post-COVID era. What happens to these patients? What are the implications? And there is an emerging, well-recognized entity that is now known as long COVID. And we need to understand that the effects of this pandemic, remember, is just about a year old. And we are learning many new things every day. In fact, just today, one of our main pillars that we would have considered part of our treatment, many of you would have called me at various times to have comments on remdesivir. Well, the WHO has just earlier this morning released new guidelines and recommendations as it relates to the use of remdesivir in hospitalized patients. I haven't had a chance yet to scrutinize the details of it, but certainly it's a shifting position on a daily or monthly basis as we know more and more evidence becomes available. So all of you, especially on my Guyana crew, you want to know what's happening locally because that's where a lot of the interest is. And let us look at, the really sick people who were sick enough to be admitted to the COVID ICU at the Georgetown Public Hospital. At the beginning of this pandemic, when it touched Guyana in March of 2020, we were unprepared from an infrastructure point of view, from a human resource point of view, from a technical point of view. Every matrix, every measurable and recordable matrix that you would need to prepare yourself, we were unprepared at the time. And we had to put a lot of things in place for infrastructure, training, education, testing. All of those things had to be put in place. And from that March to now, the area that we developed in the Georgetown Public Hospital to deal with the sickest patient with COVID-19, we call it the COVID ICU. And people who get in there are those who are generally positive, they have overwhelming evidence from a clinical point of view that this could be COVID. So far, we have had 245 admissions to the COVID ICU at Georgetown Hospital. And if you think about the national data of over 4,800 positive cases, I believe, that's a small percentage of those overall patients for the country. So 245 admissions met the criteria for the COVID ICU. Of that, there was a total of 101 deaths. 61 of those actually occurred in the COVID ICU. 20 happened in the emergency room, 17 in the transition area, and 4 occurred on the wards. 20 persons dying in the emergency room. What that really says is that those persons actually came to hospital and died within a 24-hour period. Because when they come to the emergency room, there's usually a triage and admission. They go up to the ICU or the COVID ICU. So death would have happened quite quickly or quite soon after they would have presented to hospital. What that really means is that these people would have been sick for quite a while before coming to hospital. And so part of what contributes to that is the whole stigma of coming to hospital and then getting told that you're COVID positive and what that implies for the family, the community, and all of that. And so people would have waited until they become quite sick before they came to hospital and did not really give themselves a chance to get whatever supportive care or appropriate treatment available at the time, remembering that there is no universally accepted treatment for COVID at this point. The transition ward is something that we had to develop again because there are persons who have moderate symptoms of COVID-19 but are awaiting results. And remember when we first ramped up our testing, there were periods of up to 48 hours, 72 hours, almost a week before persons would have gotten back their results. I believe our wait time now is less than 48 hours for results to come back. And so we've moved way beyond those early stages or those hiccups. Our current situation, and this was as of last night while I was preparing this presentation, we have 7 persons in the COVID ICU. 2 of them were intubated, 1 on continuous positive airway pressure oxygenation, and 4 were considered critical. Between last night to now, we had 2 additional admissions to the COVID ICU, and 1 of the intubated persons are now extubated. We have 22 persons in the transition ward, including 4 children, and an additional 7 positive maternity patients. That's our stats as it was last night, with 2 additional admissions to the ICU over the course of the evening. So what I mentioned to you before, that COVID starts before the development of symptoms, is quite accurately reflected in this graph that you can see on your screen. And if you could assume that infection on day 1 has started, and then by the time you get to 2 weeks, that is when most persons, if they're going to develop symptoms, that's when they develop symptoms. And the commonest symptom is fever. And the other things that are associated with COVID-19 are like cough, shortness of breath, and other symptoms that we will discuss a little bit more. If you look again, the first 14 days or up to 14 days are considered the incubation period. And from the time persons develop symptoms to the first week after, like 7 days after symptoms started, that's when they can start developing antibodies. Antibodies are basically the body's, your own defense mechanisms that you develop to fight off infections. So there are 2 main types, the IgM, which starts in the early stages of an infection, and then the IgG, which starts a bit later and persists for longer. Most of what we have as rapid test in Guyana right now are antibody testing. And what that tells you is that you were exposed or you were infected. It does not tell you that you have active infection at the moment. The only confirmatory test for that, as it exists right now in Guyana, is the PCR swab test that we have to do. And that's available in Guyana here. So the symptoms, as we mentioned before, of the COVID-19 are common fever, coughing, shortness of breath, difficulty breathing, chills, muscle pain, headache, sore throat. The one that came on a little bit late in the game was the loss of taste or smell. And up to this morning, I received a call from a good friend of mine who was exposed to someone who he works with, but his only symptom is loss of taste and smell, while the index or the person who he was exposed to actually had a positive COVID test. So many persons would develop loss of taste or smell as their only recognizable complaint for COVID-19. Other things that are known to be associated include the gastrointestinal symptoms such as nausea, vomiting, diarrhea, etc. Again, I want to get back to this point about persons claiming to come into hospital, they're tested on day 1, results come back a couple days later, it's positive, and they claim, oh no, or their family, we got it in hospital. If you're positive, it means that your exposure started about 7 days ago. There is an incubation period which lasts about 4 to 6 days on average, and it can be up to 14 days. You are then likely to develop symptoms after the first week to the second week. And you yourself, if you are positive, you pose the greatest infectious risk to those around you between day 8 to 10, but that can be a lot longer as well. The best time to test someone to get a positive result is between day 7 to 10 after exposure. So if you come to the emergency room, or if someone comes to the emergency room on day one and they are tested at that time and it comes back positive, there is almost an impossible scientific way for them to be in the emergency room, pick it up the same time, and test positive. It just does not happen. They would have come to hospital with it already. So that's how a typical non-ill or not severe case evolves. In the more severe cases, when we looked at the origin of this infection, which was in Wuhan, China, as far as we are aware, infection happens on day one, symptoms start around day six. Most people, after those symptoms, if they're going to get severely ill, they would then require hospitalization just after the first week. And perhaps if they're going to need ICU care, just before the end of the second week, they would be moved to ICU. The majority of persons who recover are generally out of the ICU by before the end of the third week. And by the third week, they're considered that the virus would have cleared the body. This is a multi-system or multi-organ disease. It can affect the body from head to toe. And because it does so, we have recognized that it's no longer just confined to the lungs, it's no longer just cough and shortness of breath, but it can cause effects in the brain. There's been lots of reports of increased incidence of strokes among COVID positive patients. Of course, it can cause things like kidney failure. It can cause leaky blood vessels. And the one that I am most concerned about as a cardiologist is the effect it has on the heart. It can cause something that is called myocarditis, which is an inflammatory condition of the heart muscle that makes it weak and inefficient as a pump. So therefore, it can produce heart failure, and those persons present to the hospital with lots of fluid in their lungs, and they're short of breath and can't lie down flat. It can also cause increased clots in the arteries of the heart that can then lead to heart attack and again present to my unit with chest pains and all kinds of other stuff needing intervention. As we move across the age range, we see that the worst affected persons are those in the older age group. And if we look at the younger people from age 0 to 17, that's quite important as we look towards opening our schools and other places of learning for children in Guyana. We see that in the 0 to 4 age group, the hospitalization rate was about 0.3 per 100,000 population, versus in the over 85 age group, the hospitalization was about 17 per 100,000 population. So quite clearly, there is a very well-defined increase as persons got older in the hospitalization rate. I mentioned to you before that there is no specific treatment for COVID-19 at the moment. And persons who are infected with the virus, they should receive at least appropriate supportive care. What is supportive care? I mean, those are very simple things that we've all learned from our homes. Things like proper hydration, eating healthy food, fever relief with things like Panadol, Tylenol, acetaminophen. Those are things that could actually help in the recovery process due to COVID-19 infection. In hospital, what is available in Guyana is pretty much standard for what is available in most other places in the Caribbean and Latin America. And we have utilized significantly what we have. Things like convalescent plasma. And the science behind convalescent plasma is quite simple, and it's been around for a long time, since the Spanish flu. where you take the blood of a recovered patient with the assumption that this recovered patient would have enough antibodies or defense mechanism in their blood. You then process that and give it to someone who is still sick in the hope that you're going to boost their antibody or the defense mechanism by giving them that. And we have had a fair amount of success in Guyana with that. But bear in mind, there's no magic bullet again to COVID-19 treatment. Specific prescription medications and stuff that we have used in hospital are things like steroids, antibiotics. We have used remdesivir, ivermectin, hydroxychloroquine, vitamin C, zinc, vitamin D. Of this all, the one that actually stands out with proven scientific evidence of benefit is the use of steroids. And we employ this quite widely in our patients, and specifically dexamethasone. But other things such as the hydrocortisone and prednisone, etc., these are things, other steroids that have been shown or been used by us with fair results as well. As we look towards the longer term effects of COVID, we need to recognize that after discharge from hospital or after the initial acute phase of the infection, there are still lots of possible symptoms that can occur. The overwhelming one that occurs in these patients is fatigue, and that's often due to the effect that the inflammatory process would have had on the muscles and bones of these patients. Lots of persons still continue to have some level of breathlessness, joint pains, chest pains, visual problems, and the one that we mentioned before that's a new kid on the block is the loss of taste and smell. So there are lots of persistent COVID-like symptoms even 2 months after these persons would have been cleared or thought to have been no longer a potential issue to themselves. Most people who get COVID-19 recover, and that's something that we should bear in mind all the time, even with the high or the alarming number of persons who are admitted to hospital and the COVID-related deaths. Most people who get COVID-19 have mild or moderate symptoms and can recover due to supportive care. These are the things that we talked about before: proper hydration, nutritional intake, things like vitamin C, D, zinc, etc. These have all been shown to help our immune system and to have some benefit in help patients. Another fact to remember is that you can recover from coronavirus disease. And catching this virus does not mean you will have it for life. A very unrecognized and undervalued aspect to this entire thing is the psychological effect that it has on patients. And we are recognizing that after the infection, that this is one of the more important side effects or after effects that have lingered, especially those who would have been hospitalized and in an ICU setting. If you can imagine for a moment lying down in a bed with a diagnosis of COVID-19, having coughing and shortness of breath, and right next to you, there's another patient with the same diagnosis of COVID-19, having cough and shortness of breath. And if that person dies, could you imagine the psychological trauma that you yourself will go through? Thinking, are you next? When is it going to happen? All that kind of things can then lead to very similar features of what we recognize as the post-traumatic stress disorder that occurs in people who go to war and those who would have had these stressful situations. The most common symptom among patients after discharge include things like sleeplessness, fear, and anxiety. Hospitals are not very nice places to sleep, rest, and recover. There's always, especially in the ICU, there's always a monitor that's beeping. There's always lights that are on, nurses, doctors coming in to check on patients, doing vital signs. So it's not really a good place for you to rest, recover. And so it disrupts sleep pattern. It creates fear and anxiety in scenarios that I just described. Very many persons are affected by bereavement and isolation, especially if they themselves would have witnessed these things while in hospital. And especially in persons who have pre existing psychological conditions, these can be aggravated by the COVID-19 experience when they are admitted to hospital. A small percentage of person can display neuropsychological symptoms such as confusion, worry, and sleeplessness. So this is something, even though it is not my area of expertise as a cardiologist, but it is a well-recognized and respected area of discomfort that is experienced by a lot of these patients. So with that, I'd like to conclude my presentation today. And if there are any questions, I would be more than happy to answer them.
Thank you, Dr. Carpen, for that comprehensive presentation. I mean, I really, what impacted me was the end result, the long-term conditions that you can, you know, have when you contract COVID and even recovered. It can, you know, affect you further. So thank you. And I know you are off to another meeting, but guys, if you have any questions, place it in the chat or you can raise your hands and Dr. Carpin will spare us a minute or two to answer your questions.
Certainly.
We have one
Yeah,
question.
Angela, there's one. Oh, he saw it.
Sorry, I'm having some difficulty seeing the question. Can you read it for me, please?
Go ahead.
Angela?
So we have a question here from Vashani Raghubir. The question is, what level of risk are or were the 12 persons who weren't confirmed positive exposed? Hold on. What level of risk are or were the 12 persons who weren't confirmed positive exposed to while in the ICU?
What level of risk? So I assume you were talking about the first slide, or the first slide that showed the admissions to ICU, and 245 were admitted and 233 were confirmed positive. Now, there was anytime you are in contact with a COVID positive person, there is a risk that you may develop the infection yourself. And what is considered a direct contact or exposure? You would consider persons being exposed if they're spending more than 15 minutes within 6 feet or 2 meters of a confirmed or symptomatic person, especially without wearing a mask. So you're quite correct to assume that there was some risk involved in the exposure of persons, of those 12 persons. But bear in mind that there was compelling clinical evidence to suggest that these persons actually had all the characteristic features of COVID-19, including the radiologic evidence. And let's remember a known scientific fact that there is almost 1/3 of persons, depending on the time of testing, that you can have false negative. So false negative results are quite real, and you have to be able to balance that knowledge with your clinical assessment of these patients based on what you know of the disease process.
Thank
Thanks, Dr. Carpen. There's another question here from Mia Ritchie. Are there diet restrictions for COVID-19 positive patients that will aid in them recovering quickly?
I'm not aware of any particular dietary restrictions. I can tell you what some of the recommended intake would be like. People are encouraged to increase their intake of things rich in vitamin C. That's all the citrus that you could find around oranges, tangerine, lime, all of those things. Everything sour generally has lots of vitamin C in it. The other thing that people use with, and a lot of our older people believe in it, and I wouldn't disprove it, things like garlic, turmeric, ginger. I I don't have any reason to suggest otherwise. And hydration. We love soups whenever we're sick. There's nothing wrong with continuing that practice. Now, the one thing I could think about as it relates to dietary restrictions, like if you have underlying or comorbid conditions like diabetes and hypertension, it is critical, especially during the time of a COVID infection, to have strict control of your underlying condition. So if you have diabetes, for example, you don't want to have your blood sugar spiking up and down. So you want to be cautious and responsible with your dietary intake of sugars, for example. And if you have hypertension, the intake of sodium or salt is quite critical to maintain your proper balance in your blood pressure regulation. So I hope that answers the question.
Okay. All right. Well, since there are no other questions, thanks again, Dr. Carpen.
You're very welcome. And thanks for having me.
Okay. And now, if any of the attendees, if you would have covered COVID-19, would it be possible for you to share some of your experience you would have had during covering COVID-19 in Guyana? If there's anyone, just take the mic and raise your hands, take the mic, and we will give you the mic.
Maybe we can start with Vashani Raghubir, who would have emailed her experience to me. Vashani, you want to go ahead and share that?
Sure, just confirming that you all can hear me.
Yes, we can.
All right. Hi, good morning, everyone. I haven't been in Guyana for too long, so I haven't been covering COVID-19 for as long as many of my colleagues here. But what I can say and what really struck me during my time here, and I think it's important for me to share it with you all, was I had this one experience just about 3 weeks after being back in Guyana. This was in October. And I was walking along Regent Street and I was interviewing some of the vendors on the pavement to try to understand the economic implications of COVID-19, because while it's a health thing, it's also affecting other sectors. So I was engaging in this kind of just like a vox pop kind of situation. And it was very, very interesting to me that the third random vendor I spoke to was someone who had COVID-19. And I just randomly walked up to her and she was like, yeah, I had COVID-19. This is what happened. I was in the hospital, She explained she had comorbidities. She has a heart problem. And I think from then it kind of scared me at how close the virus is and we don't really recognize it. And it also scared me a bit because the persons around her, the sales girls, the porters, the other vendors around her, they all knew that she had COVID-19. And there was some stigma around her, but yet they refused to do things like wearing masks and just generally taking better precautions. And that was really scary for me to know that these persons know that, this is real, somebody had it, but yet they refuse to take these precautions. So that was just a striking experience covering COVID-19 from me.
Thank you, Vishani. And I know maybe a lot of the vendors, everybody have to get their daily bread. And I know that maybe a lot of them are currently in that situation, but we still have to continue to share the information, make sure that they, adhere to the guidelines. But thank you for that experience, for that testimony, Vishani. All right. So we will move on to the next presentation. Now, the next presentation, I will be making it on behalf of my colleague in Washington, Ms. Ashley Baldwin, who is the communication specialist. And she is one of the sweetest persons who is currently, unavailable to us because of a new happy member, which will be added to her family, who decided to come a little early. So she's unable to be here today. So what I'm going to do, I'm going to share my screen to make the presentation on her behalf, and our colleagues in Washington will assist in any of the questions that you may have. Let me share my screen now. Can everyone see the screen? Just let me know. All right.
Yes, we can see it.
Great. All right, so the presentation I will be making today is Journalists and COVID-19. And this presentation will be teaching us how to, cover pandemic without spreading erroneous information. The documents you see here can be found in the link that you see in the middle there, can be found on the website there, and you can also have a look at all the other communication information we have on that site. I think I've shared these documents with you a couple of months. Maybe they got lost in your emails, but you can go back to the site and you'll be able to have access to these documents. Now, why would we want to have this conversation? Now, the objective for PAHO is to save lives, protect the healthcare workers, and also to flatten the curve. How do we intend to do this? We intend to do this by offering truthful information that can help reduce health risk, prevent and reduce the spread of the virus, and avoid overwhelming health services. As you know, our cases today, they are rising, and the capacity of our health services is very overwhelming, but we would like to reduce that. We would also want to confirm and avoid disseminating erroneous information and rumors. We know when we first started, there were a lot of rumors concerning the coronavirus, and we had to do a lot of information sharing, making videos, flyers, and those things, and also interacting with persons in order for them to understand. We need to connect rapidly with the public in clear language that is easily understood, for the man in the streets to understand what we're saying. So we will not go with the technical language. We just go, you need to wear your mask, you need to wash your hands, those basic things for them to understand. We need to also inspire people to act collectively. So if you know that your friends are not adhering to the guidelines, you need to encourage them, give them the information and say, this is what we need to do in order for us to flatten the curve. What we need in journalism, we need ethical and responsible reporting. We need commitment from you. We need you to educate and inform the public, not to sensationalize or be an alarmist. to them, because we know that there are some news agencies who people depend on in order to get the right information. We need that reporting, truthful reporting, which means that your information that you will share have to be received from an authentic source. Use reliable sources, as I said just now, and confirm your information. Whatever information you receive, if you have to confirm it with the Ministry of Public Health, you heard some information from PAHO, you can do the confirmation via email, or you can request an interview through the Ministry of Health. Now, some of the challenges I know that reporters face, or reporters may face, reporting in a condition of uncertainty. Okay, we don't know what will happen. We don't know when the pandemic will end. We don't know what's the next step. Okay, but we just have to be mindful in our reporting. Changing information, as Dr. Boson said, the numbers changes as we speak. Limited access to experts. We know that this can be very challenging, especially if those experts are in meetings all the time. I know that you had those experiences, but sometimes we just have to think ahead, to plan ahead and to make our appointments, early or in a timely, or even send the information via email. Time pressure to get the news out. This, I know you guys face. Sometimes I will receive a call or an email that I have to submit this news piece on Wednesday. Is it possible for me to have an interview with your PWR and so on? So I know time pressure is one of your challenges. Confinement and curfews. Many people these days go through that, but we all have to do the work and also be mindful of the curfews, the curfew guidelines. Contradictory messages, that is something we also need to be mindful of, and changes in distancing measures. I know when we first started, it was 1 meter apart, but then due to the research done, 2 meters and more. So these are the challenges: insecurity and also trust. We need to keep in mind that the news media have a key role in building people's trust. And I am telling you, this is very important. I know the other day, someone saw something on a website and they said, is this true? And another individual said, is it on Gordon Mosley's page? If it's not on Gordon Mosley's page, it's not true. So people trust the news sources they go to, and which means that you have an important role in sharing the right information in order to continue to build that trust. A population that trusts the authorities will follow the recommendations for prevention. That is so true. More responsible we all are in prevention, the better chance we will have to mitigate the effects of the virus. And that is so true. So we all need to keep those in mind. Important points for building trust. Each of the panelists reiterated this: use reliable sources. We all need to use reliable sources. Use credible spokesperson with technical and scientific know-how. So when you need to verify your information, when you need to have the technical aspect of the whatever topic you're researching, from the entity, the spokesperson will have to be knowledgeable in order for them to share that information with you, and in order for you to share that information with the public. Avoid repeating unfounded rumors. Always find out what reliable sources have to say, for which you do a lot. And we're very grateful for that. Now, as the minister mentioned, infodemic. Now, this became a reality in a few months ago when information was coming from all over, and persons were so confused, they didn't know who to believe. So just to give a short definition, an infodemic is an information epidemic. An overload of information, facts, rumors, speculations, amplified by technologies that make it hard for people to find trustworthy sources when they need them, especially on social media networks. We know this. And one of the problems that we find is that it makes the health crisis harder to control, which is very true. So, a statement the WHO General Director, the Director General said, Dr. Tedros Ghebreyesus, on the 15th of February, he said, not only we are fighting an epidemic, we are fighting an infodemic, which is true, because there's a lot of information out there and people will grasp whatever information, that they feel is true. So he said, it is time for facts and not fear. It's time for science and not rumors. It's time for solidarity and not, time for solidarity and not stigma. Because oftentimes, and when the virus came, a lot of persons were being stigmatized. I can give you an example. We interviewed a nurse whose husband died from COVID-19, and she lives in Georgetown. Both herself and her husband, they live in Georgetown, and her family lived in Berbice. And her family in Berbice were stigmatized because her husband died from COVID-19. Mind you, they live in Georgetown. So her family in Berbice felt that stigma. Persons weren't going around them, weren't visiting, weren't even calling them. And that affected her. And at that time, she was pregnant, but she did not have COVID-19. She was found negative. Soup of disinformation. So we need to avoid stigmatization, as I said, and rumors. Do not contribute to the panic. And as we saw over the months, China was blamed for everything. But we need to be mindful and not contribute to that panic, but to share the right information so that persons can, adhere to the guidelines and practice the guidelines to keep themselves and their families safe. Report with evidence and reliable sources. Offer advice that can help reduce anxiety, prevent cases, and mitigate the disease. Now, here are a few tips that we can follow. We can promote protective measures. Let them know that they need to wear their mask. Until a vaccine is here, we need to wash our hands, practice social and physical distancing. We need to bust myths. For instance, when we first started, a lot of people were in the market buying all the ginger and all the garlic, and people were saying, oh, coronavirus would not survive in Guyana because we have a hot climate. That had nothing to do with you not contracting COVID-19. Look at us now, we're 4,000 plus, and persons are asymptomatic, so you don't even know who's out there with the virus. All these things do is to build your immunity. The ginger and the garlic, they build your immunity. And that's what we had to explain to the public. Explain to the public health concepts in a simple way. Put the figures in perspective. Provide information on when, where to seek medical attention. Report progress on new vaccines and treatment. Now, before publishing stories found in social network, make sure they are true. Provide links or cite reliable sources of information. So as one of our panelists did, she provided all the links that you can actually go on to have information or to verify some information that you may have. We need to avoid sensationalized language, avoid fueling fear, avoid stigmatizing people and groups. The example I gave earlier. Avoid labels, stereotypes, and discrimination and discriminatory treatment in general. I remember our healthcare providers were discriminated against because while they were nurses looking after persons who are ill, they were not allowed to go in our public transportation. They were treated in such a way that if you come in this vehicle, you will infect everyone. So citizens had to take it upon themselves to transport those nurses to the hospitals and back to their homes. So we need to be very mindful of this. Do not use terms like Wuhan virus. Alert the public, but do not exaggerate. Offer practical advice on how people can deal with the situation. Avoid repeating unfounded theories or claims with no scientific basis. So all your information must be scientific, proven. Avoid telling the other side of the story. If it has no scientific basis or is ridiculous or incredible, do not speak for the other side. Now, WHO and UNICEF, and along with the Red Cross, would have provided some guidelines on discriminatory messages or behavior that can lead to people. So it can lead to people hiding the disease to avoid discrimination. So based on the stigma and the discrimination, you may not find people going to the health centers or even calling in or even allowing anybody to know that they have that disease. Discourage them from seeking prompt medical care. Yeah, and this is, as I said just now, they may not want to contact the health center. They may not want to go for medical treatment. Wording is very important. It is better to say people with COVID-19 than cases or victims. It is better to refer to people contracting the virus rather than spreading the virus. So our wording, very important. Other recommendations for avoiding social stigmatization. Keep a positive tone and emphasize the effectiveness of the prevention measures. Share stories that humanize the experiences of people affected by COVID-19 and stories that show support for health workers and others on the front line of the response to the outbreak. And we must be mindful, and we must know that we are all in this together. All of us, we are all in this together. And this is not the first pandemic, and it would not be the last. But we have to help each other in order for this virus to, for the curve to be flattened. This ends the presentation. Thank you on behalf of Miss Ashley Baldwin. If you have any questions, just post in the chat, and we will be able to answer your questions. Thank you. Our next presenter will be Mr. Javier Munoz, who is the social media specialist in the PAHO Washington head office. Javier, take the floor.
Good morning, everyone. This is Javier Munoz. But before I start, any questions for Angela? Angela, I don't know if people ask questions, and then you want me to go ahead with my presentation, or what do you prefer?
Yeah, well, I asked them if they have any questions. They can place it in the chat. We can see it.
Nothing so far, right?
Yeah, nothing so far. So you can go ahead.
Okay. So while I share my screen, so good morning, everyone. My name is Javier Munoz. I am the social media specialist at PAHO based in Washington, D.C. It is a pleasure to be here with you. Thank you for the invitation to Angela and the colleagues at the Ministry of Health. And this is, I hope, the first of several sessions, because social media is a learning process, as all of us know. And this is today our objective is to explain you how we've been using social media at PAHO during the pandemic. I mean, even before it was declared a pandemic, and what's working for us, what opportunities we have ahead. So, but I'm sure that maybe some of you would like a more hands-on training session, and hopefully we could schedule that for the coming months. So I will share my screen. Ta-da. Can you see it now?
Yes, we can.
Okay, thank you. Now this is social media. So I want you guys to get in the social media conversation mood, because everything that we post, everything that we do on social media is leads to a conversation. So anything that we do from our different organizations, from PAHO, from the Ministry of Health, I'm sure for you for the different organizations that you represent, the media houses, you know that every time that we post something on social media, we are opening a window to establish a dialogue. So this is different that, as we know, that from the times when we had websites, when we were just publishing content on static web spaces. Now we are having conversations. So this is why it's so important to understand the different platforms that we have available inside, in your case, inside and outside your country, because we live and interact in a globalized and interconnected world. And with so much information, and I'm going to talk about this more later, we need to be aware of all those platforms, all those conversations that are happening on the different channels, platforms that we should be paying attention to. So just let me, just to raise the ice here, I want to know if you can write in the chat, if you could tell us in the chat which social media platform are you use the most. Just write one or two. I know that in Guyana, the most popular today are Facebook, Instagram, and Twitter. But I know that most of your journalists, so many journalists, as we know around the world, they are using Twitter as a default social media platform, not only to have conversations, but also to find information from decision makers, from fellow journalists, from governments. So please go, if you feel like, share with us which social media platform do you use the most and you enjoy using the most? So I'll look at your chat. So in the meantime, I'm going to start with the presentation. So, oops, let me see here. Angela, I know you told me before how to move the slides, but now I can't.
Just use your down arrow on your keyboard.
Which one? Oh, okay, good. Yeah. Okay, social media. As I mentioned before, social media is our conversations. We moved with these new technologies from passive to active communications. No, social media technologies change all the time. So in PAHO, we've been having the use of social media has been the evolution has been organic. We started back in 2006 with a YouTube channel, was the first platform. Then we had a blog. Then we have our first Facebook page. And since then we have, let's say, go hand in hand with the evolution of technologies. Today, our social media conversation is primarily is based on Facebook, Twitter, Instagram, and LinkedIn. Those are the four main platforms that PAHO is using today. And this pandemic, as you will see later, has represented an opportunity. First of all, our responsibility. Second, an opportunity so we can maximize our efforts on how we communicate the key messages, the key documents, the most important learning resources with different audiences on the different platforms that we use. So when we measure social media, we always look, we determine our success in terms of impressions, which is the number of times someone, a user of any platform, sees our content, regardless of the number of followers we have. And you will see this, I will explain this later. The reach, how many people actually not only see, but receive our content. Because sometimes it's just, when we talk about impressions, imagine you are with your phone and you're scrolling down on Twitter. And even if you don't click, the content is on your screen. That does relate to impressions. Reach is the accounts, the people that see them, get the message, regardless if they see it or not. And engagement is what our social media users do with our content. They can comment on it, they can like it, they can share it, they can add a favorite, and or they can and they what else? And they also have comments, shares, likes, and faves. So this is engagement. Click on the link of our website included in the message. I'll show you some examples later, or even view one of those short mini clips that are so popular today in social media. Now, this is I'm mentioning these numbers because I did some research, and I also spoke with Angela, and I know that, of course, we know that the English is the official language in Guyana, but we also know that there are other communities that live in your territory, and sometimes there is a need to communicate and to engage with them, especially from the health authorities' perspective. So PAHO social media presence includes 20 sites on Facebook, 20 sites on Twitter, one on Instagram, and one on LinkedIn. We post, in general, in Spanish, English, and Portuguese. The total number of followers on each platform, regional plus country size, and when I say platform, I am referring to all the Facebook universe. We have more than 3,800,000 followers. On Twitter, we are, I hope by the end of the year, we get to 900,000. And on Instagram, which is, by the way, the fastest growing platform, and I'm going to talk about this later, we have we are growing by the week, very, very fast. We're getting thousands of followers every month. And today we have more than 320,000 followers. LinkedIn is a more specialized platform, and we have more than 46,000 followers. In total, PAHO has a social media audience of more than 4,700,000 people. This just based on followers. But as I will explain later, and as many of you should already know, social media performance and success goes beyond the number of followers. Okay, before March 11, when COVID-19 was declared a pandemic, we were already working from the communications department on addressing the crisis. So not everything within communications and on social media during this pandemic is based on these principles that you see on the screen. Information is the most important resource to enable a population to make informed decisions. We as communicators know that we always need to validate our sources. And now during this pandemic, our social media accounts have become a point of reference in many groups, the default source of information for journalists, for governments, for UN agencies and other partners. Our priority is to inform social media users about the health risks posed by COVID and measures that they take to protect themselves. So this includes, of course, the general population, but when we talk about measures, we also have a responsibility to communicate and engage with our primary audience, which are the ministries of health in the countries of the Americas. PAHO participates in the social media conversation with timely, evidence-based information. This is why we encourage you and we invite you to always pay attention to what we are posting. We've been talking about infodemic this morning. We've been talking about, we are not only now combating the transmission of the virus, but we are also combating this infodemic that we have today. So I think that in social media, on PAHO's social media channels, you will have the most updated and the evidence-based information when you need it. Everything that we post on social media, week by week, the different topics that you see that we address are in line to the evolution of the response to the pandemic. So this is why, and there is a process behind, I will explain this later, but for example, this week, today, actually, we are having Facebook Lives on the use of antibiotics during the pandemic, because we are on a 1-week campaign of antimicrobial resistance awareness. The week before, we also had Diabetes Day, and when that's, as you know, people with that persistent condition are more how do you say, are more they have the precondition to be exposed to a virus and have their health affected. So everything that you see week by week is either because we have major campaign, a regional campaign, but also because we are addressing a topic that is of importance to the region. Contact tracing, for example. 2 weeks ago, we started a campaign on contact tracing. The importance of vaccination. We also started a campaign highlighting why vaccination is so important during the pandemic. Why countries should continue with the vaccination plans for the population. What else? Also, as you have seen or will see in our social media post, we have a combination of messages and graphic and video materials tailored to the audience of the different platforms we use. As I said, everything we do on social media, PAHO, is a team effort. It's a team effort that includes not only the work of the communications department, but very importantly, the contributions and the clearance of the technical teams involved. We have a rigorous process to clear every piece of content that is published on our social media channels. And of course, everything that we publish is public, and our main source of information is the web, PAHO.org, and I will tell you more in a minute. Okay, what's working for us today? Since after March 11, when the COVID-19 pandemic was declared, we started to host weekly virtual media briefings with our director. So we took this as an opportunity to maximize the use of our social media. How? We started to broadcast live on Facebook and Twitter, but also we started to share key messages from the director and other authorized spokespersons of the organization as they were delivering their remarks in Spanish, in English, and Portuguese simultaneously on 3 languages. And then we also, there is a round of answers to journalists, and then we took those, from those answers to journalists, we take key messages and we package them in short videos or postcards. And this is being very, very effective. This has helped us tremendously to gain, to expand our reach and engagement rates on social media, and of course, our followers base. Since you are a group of journalists, and I'm sure through Angela and from our organization, you received information of an invitation for our weekly virtual media briefings. These media briefings and the social media coverage we provide will give you access to the official and updated information on the different aspects related to response to the pandemic. I mean, if you go to Twitter, just on Twitter, you will see in the PAHO WHO account all threads of key messages with so important information for the public, for decision makers, and for journalists. So I encourage you I know that in some circles, Twitter is not as popular in Guyana, but we all know that for journalists around the world, and for decision makers and governments, and your government too, Twitter is a tool that we can afford to not be engaged with. In addition to our weekly briefings, we are also connecting the voice of our experts with our audience on social media through a new series, not that new anymore. It's called Ask the Experts. It's week where we have thematic conversations on different aspects of the response to the pandemic. We started on Facebook, Spanish and/or English, and now we are doing simultaneously on Twitter. And this has also helped us not only to respond live to questions, but also to build on our Facebook page a repository that is a reference of basically questions and answers on different topics of the pandemic. So I encourage you to visit facebook.com/PAHO, WHO, go to videos, and then you will see, I believe there's a library with all the Facebook Lives that we have. And most of them in the last 6 months are either as the experts and the broadcast of the press briefings. What else? Oh, a commercial today, 2 p.m. Washington time. I believe that's 3 p.m. Guyana time. We have a very interesting Ask the Experts conversation on the use of antibiotics during the pandemic. So it's going to be hosted by our focal point in Bahamas. It will be a conversation with from the Caribbean perspective. So we recommend you to connect and feel free to ask us questions during the broadcast. today at 2 p.m. Washington time, 3 p.m. Guyana time. Now, engagement, of course, engagement is so important for us. But as we know that social media platforms, particularly Facebook, which is the most used platform in the region, is so popular in our countries, including Guyana, we are also using Facebook to give visibility to our efforts, how we work with the community. And here on the screen, you will see a post that we made, that Angela made in early in June, informing the local community about one of our donations of materials and other resources, PPEs, etc. So I think that this is we must use also Facebook to show and share with the community how we are working for them. On the right side, you will see there is a video, a 58-second videos, and I'm emphasizing the length of the video. As you see more and more on social media, we are producing and posting videos that are short, touching, and crispy. This one comes from Bahamas, and it was shared a month ago, and it emphasizes on the importance of wearing a mask and physical distance for people in regards to something as common and important for everyone that's going to church. So this was I post this video because actually in the last 6 months is the most popular video that we have on the PAHO Caribbean PAHO page. So yes, we have a main page, PAHO WHO, and then we have the PAHO Caribbean page. Both are with sources of information of interest to you. But of course, the PAHO Caribbean is tailored to your to a Caribbean community. Twitter, as I mentioned before, Twitter is a social media platform that perhaps is the second most used platform in the region, especially among decision makers, academia, journalists in different countries. And as I said before, I think that even though for journalists or for the public in general in Guyana, maybe it's not as popular, I think there is an opportunity for journalists and everyone working in communications and government and international development to be on Twitter, because most of our partners, most of our UN agencies in the sub-region, you have CARFA, CARICOM, the Health Coalition Community, and others are on Twitter. UNAIDS Caribbean. So you always, on Twitter, we have quick access also to information that is presented in a shorter format in terms of text, where there is always like a call to action, as in most of our social media posts. And here on the left, this is one of the top posts. I think this was on a few months ago. It reached more than 104,000 people or users of Twitter. And here we are sharing a message for the health sector workers, but also if you read closely, we say and learn more, what can you do to help eliminate domestic violence? And here there is a message for those workers, those decision makers, and everyone working on legislation. So we try to combine those two objectives in our communications. On the right side, there is a popular post also. It was a top post, and this relates to how we are contributing to the capacity building in Haiti. So it gained so much attention, and we managed to reach more than 180,000 users of Twitter with this single post. Now, expanding our presence and engaging with important and dynamic communities. Youth, in general, youth, and when we mention youth, we're talking about teenagers, students, young professionals, and everyone, let's say, and I was looking at trends, Instagram trends the other day, and anyone between 18 and 35 years of age. So that segment of the population, regionally and even globally, is using Instagram the most. This post on the left is from Instagram, and it was very useful for us as it helped us to fight misinformation among users of the platform on something. You see that example on the screen. There was for several weeks there was this news, fake news, that garlic could help to prevent the infection with COVID. Of course, as I said, it was an opportunity for us to use these materials and share. Now, looking at the materials, you will see that in PAHO's social media posts include either content that we produce in-house in the region, in Washington, or we adapt content from Geneva to our region. We adapt because sometimes we need to make a little adjustments in the terminology, in the language. So this is one of them. This came originally from Geneva, and we adapted the content with our logo and other changes in the vocabulary. On the right side, you have an example of LinkedIn. LinkedIn is as we know, is the most popular professional networking platform, I would say, in the world. And it helps us, even though the audience is smaller in terms of numbers, it helps us to reach those working not only in the health sector, but in other areas of development. So it has proven to be very effective to promote learning opportunities, either webinars or new publications, trainings, and this is a recent example. We would like to emphasize also to pay attention to our social media content promoting learning resources. We have a hashtag, it's PAHO Publications. Everything you see on any social media platform, but mostly on Twitter and LinkedIn, with the PAHO Publications hashtag, is a resource that we are sharing with our audiences, and we are trying to post at least once or twice a month, either on a new publication or even we have also a newsletter that we promote and advertise on social media. We also have a virtual campus. Here is an example of audiobooks that we produce and share they have two accounts. I'll share the links later. They have one account on Facebook and one account on Twitter. But we also share their content on our other regional platforms. But our virtual campus is full of resources and training options, either for self-learning or with a tutor. So let's take a look. I'll just go to any of our, so even on our PAHO.org, you will see a link to our virtual campus. I think it's at the bottom of the screen or under the resources, but also you will find the virtual campus, which unfortunately the number is in Spanish, the name is in Spanish, Campus Virtual SP, that's the name. I'm taking note because we may have to make this title bilingual, but you will find this on social media, Campus Virtual SP. On the right side, there is an example from the PAHO Caribbean page, and this is with a manual. You know, there is a very popular campaign that actually this week, as we speak, we are pushing this campaign on the PAHO Caribbean side. It's a Stronger Together campaign, which relates to mental health. So you will see lots of content in the coming days up to early December. We'll be posting every day different content on the PAHO Caribbean sites on Facebook and Twitter, but also on Instagram, our regional account. Okay, This approach that I have summarized with you very quickly has helped us to increase the effectiveness and reach of our communication efforts, and at the same time enhancing the organization's visibility, reputation, and relevance. Uh, we are, I mean, we need to be humble, but I think we are more and more recognized of social media influencers in the field of public health and during this pandemic. Uh, Thousands of people are looking at our posts and referring and using them as a decision-making tool, as a learning resource, but they're paying attention. And we see this in our reports. We monitor, of course, this is internal information, but we produce weekly social media reports where we look at the performance of our content on the regional accounts. And basically, we look at three metrics, the most important: reach, impressions, and engagement. So that's what we look at. And the numbers are, since since March 11, the numbers have increased significantly. We've never seen those numbers in our social media history. So this is an opportunity, this is a big responsibility, and we are trying to maximize the use of our resources to make sure that we are active and present in the social conversation every day. And please don't forget these resources I have on the screen. Our website, paho.org/en/COVID-19 communication materials. Here you will find not only an introduction to our communications approach, but also you will find materials to download and share on your social media with everyone. It's information available to the public. So we encourage you to visit our website. Facebook, we have four main accounts that are a good reference for you: the PAHO Caribbean account, the PAHO WHO account, the Campus Virtual SP that I just mentioned, and PAHO Emergencies. PAHO Emergencies is a technical account, but they provide updated information, for example, on the different reports on like technical reports on different not only on COVID but other infectious diseases and outbreaks that happen in the region, because we, in addition to COVID, and this is also important for you to know, we have other health topics, we have other health challenges and issues that we need to address on social media. So now we are trying to balance to be present and the response to the pandemic, but also to continue working. One example is there is a global campaign on the elimination of the neglected diseases. We, in some areas of the region, we have an emergence of dengue, malaria, chikungunya in some areas, in some countries, and we need to influenza. So we need also to use social media to share our messages for decision makers, for the general public, and for the different audiences that we interact with. Twitter. On Twitter, we have PAHO Caribbean, of course, PAHO WHO, Campus Virtual, and PAHO Emergencies, the same as Facebook. Instagram, there is only one account as of today, OPS PAHO. But very soon, you will hear from Angela, and hopefully we are getting ready to launch at this account. Most likely, crossing fingers, will become OPS OMS in Spanish, and we will have a dedicated Spanish for English. We are preparing for this. Hopefully, it's going to happen in between the end of the year and early next year. We need to plan a transition process. LinkedIn, you will find us as Pan American Health Organization. Just type this on LinkedIn and you'll find us. And YouTube. YouTube used to be a repository of videos for us, but lately, with the current situation, it's becoming more and more a place for live, a space for live broadcast, and we are now even thinking to have more interaction with the YouTube community. So we invite you to subscribe to our channel at PAHO TV and where you will find different playlists on different topics, including there is a playlist. If you want to have a quick access to our media briefings, all the recordings are here, and also for our Facebook Lives. You go to YouTube, you type PAHO TV, and subscribe to our channel, please, and share with everyone. So I know this has been quick. I don't know, Angela, how are we time? Do we have time to answer questions? Can I share some of our sites that I have opened here? I know this is the beginning. I hope we will meet again, hopefully to have something more hands-on, and we teach you some tips to manage your Facebook, Twitter, Instagram, LinkedIn accounts.
I'm sure you're 5 minutes.
Okay. Now, I also, we want to emphasize that we want you to follow us and of course the accounts of the Ministry of Health. We know the Ministry of Health is on Facebook, Instagram, and Twitter. And as I'm going to show you right now, I'm going just some examples of the type of content that we post and that works the best for the different platforms. Here, share the screen. And, okay. Here. What do you see now, Angela?
Yeah, we're seeing the screen.
Facebook, the face. Okay, no, this is LinkedIn. But let's go to. Okay, this is Facebook. This is Facebook. And this, we have several pages, as I mentioned, but the main regional page is PAHO. Oh, I did something wrong. 1 second, because David gave me a tip. 1 second. And stop sharing. Here, here. Done. Okay, here. Okay, this is the main page, PAHO WHO, but we also have the PAHO Caribbean page that I'm sure everyone here is following the page. If you are not, please do. And if you're not using Facebook, please get back to Angela and myself, and we'll be more than happy to give you some tips to open an account and to manage it properly. But I just wanted to show you, this here on the screen. Can you see? This is an example of the campaign I mentioned, the Stronger Together campaign. Please pay attention, please share, because this content is tailored to user region, to a Caribbean, and it's so important right now in the context of the pandemic. But I wanted to share a video. No, maybe so. Okay, so here, let me go back, please. So here are examples of posts. Notice the graphics, the material that we are using for the different campaigns. This is one on cervical cancer. I know it's not COVID, but I just want you to pay attention to the type of graphic content that works the best. This was recent. This was, we promoted this youth hangout or live conversations that we hosted with UNICEF. And the last one of the season was yesterday, actually. So on Facebook, the Facebook audience in general, in most of the countries, and we have analyzed our Facebook audience with Facebook. We work with Facebook and Twitter, the companies, and they help us to be more strategic on how we use these platforms. And on Facebook, we always use language that is easily to understand to the public. We use materials that are attractive. We use materials that have not too much text like this one, just basic information. And this works excellent. So this is just an example, but I don't want to miss the opportunity to show you this one. This is Instagram. And from Instagram, Instagram. Here, this is our web desktop version of view of Instagram. But I want you to see, look at, let's see, like this one. Is this Spanish or English? This one. This is the, when we are on Instagram, I don't know if everyone can hear. There's some music for this. Oh, maybe there's no sound for this clip, but I'm sure you're looking at this. We
At the bottom, you see the volume.
go
Click it
where?
on your right, on the right side of the screen there.
Yeah,
You see the volume
where I.
bottom, at the bottom.
Hi, Aria. Next to the add a comment, you'll see that your audio is muted for the video there.
Oh,
Yes.
Good.
I never use Instagram. Those that work on Instagram, we know that we always manage Instagram with the phone. I only go to a website to look at them when I make my reports. But when I manage Instagram on the phone. So yeah. Okay, you got an idea of the type of content that Instagram users, we have used this in other platforms, but this was, we are developing this type of materials for mostly for Instagram and Facebook, especially on Instagram where we have a young audience. They like to see color, they like to see attractive text, they would like to see short messages, and we are working on this. So this is just an example. Then we have here Instagram. So on Instagram today here is the invitation. This is in Spanish, but we promote learning opportunities like the Facebook Live. We are also now sharing, and I want you to pay attention to this series of videos. It's called Science in 5, produced by Geneva, and we are posting our regional channels. In your case, of course, with no subtitles, but we are also adding Spanish and Portuguese subtitles. So this is a series that is also available on YouTube. They are 5 minutes long, and we are sharing them on LinkedIn, Instagram, and of course, YouTube. We invite you to take a look. WHO releases a video every Friday, and we are catching up because we started the dissemination later. So we are not always, the video that you will see on our channels will be maybe from the weeks before. But today, I think they're launching one on that you can look at WHO's YouTube channel. But okay, I think that now you have an idea of the flavor of of our social media presence and what is working for us, what is our approach. I know that you are a small community, however, you have different audiences. I was surprised yesterday. I was speaking with Angela, and I now content in Spanish. Sometimes there is a need now to have content in Spanish for those communities, perhaps close to a border with Venezuela, that may need information in Spanish. So we help contribute in the transmission of the virus, on educating people. You also have Amerindian communities in your country. So I think it's important that we as communicators, and you as journalists in particular, we take advantage of that in the sense that we need to interact with them. We need even to listen to them and get to them. Sometimes in here, even though I work on social media, sometimes there are so many people in our region, so many communities, that perhaps the only way to communicate or the only resource they have is radio. Or sometimes we have people in our region that don't know how to read, or maybe we need to be innovative and don't forget about how those vulnerable or remote communities in our different countries are consuming information. I think that's important. So we need to keep a balance, I think, in the how we use social media, how we use radio, how we use other types of tactics to inform, educate, and fight misinformation, because we're just not fighting the spread of this virus, but we're also fighting the spread of misinformation, which is pushed by these technologies that we have today that help us so much, but at the same time that we need to control and mitigate. So, okay, so that's it. I hope you found this information useful. I hope this is the first time of several sessions to come. And now I open the floor to your questions. Thank you.
Thank you, Javier. Very good presentation. For the remaining attendees, do you have any questions? You can just raise your hand, or you can type in the chat box. But we don't have any questions, but I guess they will send their questions to my email later. But this was a very good webinar that we had today, and I would like to thank all the panelists, all the attendees. We have some of our regular attendees still on the webinar, and we would like to thank you for staying with us throughout the webinar. So thank you. Do you have anything else to say? Shabana, would you like to say anything?
Hi, Angela. I would just like to extend our heartfelt thanks and appreciation to PAHO, Guyana, and Washington for putting this training together, assisting us. It was much needed. And like Javier said, we hope that this is the first of many more to come. So on behalf of the ministry, we'd like to say thanks again.
Thank you, Shabana. And as Javier mentioned, there is a Facebook Live coming up at 2 o'clock, 3 o'clock our time. Yes, 3 o'clock our time, and maybe you guys will be able to join, and you can, listen in to even have an article done on that. So thanks again, everyone. It was great being here with you. Thank you.